Hello, everyone. Good evening. Welcome to the AAHS Practice Series webinar, where we will be talking about optimizing APP integration in a modern hand practice. We have a variety of webinars coming up this year, focusing specifically on practice series topics as opposed to clinical topics, which are also available. I wanted to thank our panelists for being here, as well as all of you for joining us. If there's any questions, please put them in the chat box. We'll be happy to answer either through the chat or I'll have our panelists answer as well. Without further ado, I'm going to introduce our moderator, Dr. Samir Puri from Indiana Hand, who will introduce our speakers and get us going. Thank you, Samir.
Thank you, Sahi. Welcome to everybody. Really looking forward to the talks tonight. We've got a great panel for you. It's also a nice opportunity to spend some time. A lot of these webinars are about things that might interest us in some ways, but this is really a topic that can make your life a lot better, make your practice a lot better. So it's a really great way to spend an evening. We've got a great panel. Dr. Reed Hoyer is one of my partners at Indiana Hand Center, and he's got a great business mind and a lot of interest in the practice of in the business of medicine. And he's going to talk to us about the justifying a need to hire an APP. Dr. Alex Hahn is in practice in a very complex practice in Baltimore and can use all the help he can get. And so he's going to talk to us about hiring and some thoughts on that. Chrissy McAndrew is a PA who's got experience both in clinical practice but also in a leadership role as a director of their group of the APPs at Penn Medicine. And Mike Vosbeekian is a program director at Rutgers and a committed educator, and he's going to talk about some of the balances that many of us face as we think about optimizing efficiency with teaching. So without further ado, I'm going to pass it off to Dr. Hoyer to get us started.
Should unmute and put my video on first. Here we go. All right. Samir, let me know if you can see my screen here.
I can hear you, but I'm not seeing your screen right now unless I'm...
Okay. Share.
And there it is.
Apologies. All right. Well, good evening, everyone. And thanks to Samir and Sahi for allowing me to join. Sorry for those minor tech difficulties. I'm going to talk with you about justifying the need for an APP and when you should think about hiring one for your practice. Just to give you a little bit about me and my practice. I am in private practice in Indianapolis. It's a academic practice for sure, but I'm an owner in an orthopedic practice with an associated orthopedic hospital ownership. So the cost of hiring a personal employee, such as a PA or a nurse practitioner, are mine, including the benefits that that person receives, including their health insurance, dental insurance, et cetera, and their 401k. So these costs are not supported or covered by a hospital. I think that's something important to keep in mind depending on your practice. Some of the calculus may be different for hospital employed surgeons, but I do think there's significant crossover in decision making otherwise. And certainly asking the hospital to help support a PA may have some implications for your salary. So I think there's a lot of similarities in decision making when hiring a advanced practice provider. So should you hire an APP? Well, I think this answer really tends to be very personal, and the individual factors and the weight each of us apply to those individual factors will differ amongst all of us. However, I think there are several general considerations that are likely to be widely applicable, and these include practice considerations such as patient wait times, lifestyle considerations, and finances, including direct and indirect costs of hiring an APP and direct and indirect reimbursement the APP can provide to your practice. So I'm going to talk about each of these things. First, we'll start with patient and practice considerations. When it comes to thinking about your practice considerations, I think you need to not only answer the question of how busy are you, but also what's making you busy. So what do I mean by that? For example, if you're spending a significant amount of time and energy on documentation, if you're waking up early or staying up after your family goes to sleep to dictate notes, maybe the answer isn't an APP, but maybe you need to hire a scribe or invest in some of the newer AI technology, which is getting better and better. If you're having trouble keeping up with patient phone calls, returning calls when they call, providing pain scripts after surgery, or providing imaging or testing results, et cetera, potentially it's asking your MA to do more for you and cover some of those phone calls and giving results. Or maybe it's a combination of all these factors, with longer scheduling wait times to get new patients in. And also maybe you could use some help in the operating room. In that situation, it is likely that an APP is going to be your best solution. So understanding what's making you busy, I think, is important before you answer this question. One of the practice goals should be seeing more new patients, as new patient volume really is highly correlated with revenue and surgical volume. In fact, one of the statistics that we used to track was revenue per new patient, and this was simply the total revenue of the practice divided by total new patients, and each new patient on average provided that much revenue to the practice. So you should be asking yourselves these questions. Are wait times for new patient scheduling increasing? Are wait times for established patients increasing? Are wait times to get surgery scheduled with you increasing? As we all are aware, waiting patients tend to be unhappy patients, and the more patients have to wait, the longer they have to wait, the more they're likely to look for care elsewhere. As a general rule, I think it makes sense that if patients are waiting really more than 3 weeks to see you, you're likely to lose those patients to a competing practice in town. So the real question isn't, are you busy, but rather, are you turning away growth in your practice? In addition to wait times, I think it's important to evaluate the type and complexity of the work you're doing. Are you the most highly trained person in your immediate practice doing too much low complexity work? Are you seeing a lot of unpaid routine post-op patients? Are you doing routine follow-ups after injections or treating non-operative fractures and seeing them in follow-up? Are you doing standard testing follow-up? If this type of low complexity work is really stuffing your clinic, it means that new patients are waiting longer to see you, and you're likely losing some of those patients. You might feel busy because you're seeing a lot of patients, but you aren't utilizing your skills and knowledge where they are most beneficial, and your busyness isn't translating into revenue. And these are easy visits to hand off to an advanced practice provider. So you need to ask yourself, am I the bottleneck? If everything in your practice requires your input, you might be the limiting your practice's growth. And an APP can really remove this choke point so that you can focus your energies on practice growth, patient care, and complex problems, which is really where it should be focused. Of course, there's more to this than simply practice considerations. And in the end, unfortunately, sometimes money matters. What we're really talking about here, though, is spending money for time. So what does it cost? Well, hiring an APP is not cheap. The average salary can range from $110,000 up to $160,000 per year, depending on the practice characteristics as well as the APP's experience. And the total package, including benefits, can be as high as $200,000 per year. These numbers do continue to rise, really elevated by hospital-employed positions. And in order to break even, the hiring surgeon probably needs to perform something like 10 more surgeries per month and maybe see an extra 8 to 12 patients per day in the office, depending on the payer mix. I think that cost of hiring an APP really does depend on your practice type. Are you asking the extender to take call, for example? That's certainly going to cost more. Are they covering certain holidays, weekends, those sorts of things? That can definitely factor into their total salary, but it's certainly not an inexpensive proposition to hire an advanced practice provider. In our group, most APPs are not money makers. Rather, hiring an APP really is a lifestyle choice where hopefully the dollars come close to evening out. Also keep in mind that for many hand surgeons, many routine cases will not be reimbursed for a surgical assistant. So therefore, depending on your case mix, having an APP see patients in clinic may be more beneficial from a revenue standpoint. Here's an example of several different practice types in our multidisciplinary orthopedic group. As I noted, on average, most APPs are a cost center for the hiring physician, with a range of $28,000 in the positive to $41,000 in the red. On average, the cost is less than $20,000 per year, and that includes all of the indirect costs such as benefits, 401k, et cetera. And that does include counting revenue that has been collected by the APP. So when is it worth it to spend money for time? Again, I think this is a personal decision we all need to answer for ourselves. However, when you find yourself taking work home, taking work on vacation, when you start to have feelings of burnout developing, it certainly may be worth it to consider spending some money to get some of your time back. I also think it bears mentioning that these are not exactly dollar for dollar transactions. There are certainly harder to quantify aspects of this transaction that can be included in your calculus when you're hiring an APP. For example, hiring an APP will likely improve patient access and reduce waiting times. It will likely improve patient communication, as your APP can communicate results and return phone calls in real time while you're doing surgery. You'll likely spend less time on unpaid follow-ups, which opens up your schedule to see more paying new patients. And remember, your APP won't get paid for those follow-ups, but you're seeing more new patients. So even though it looks like a loss on their P&L, it's helping your P&L look better. And with more new patients, you're likely going to be able to schedule more surgery. And finally, and very importantly, you're going to have less stress. So none of these factors show up on the profit and loss statement, but they all can be factors in your decision to hire an advanced practice provider. So in summary, you should hire an APP when access to you is limited and wait times are rising, when low acuity work is dominating your schedule, when you could do more surgery but are limited by a busy clinic, and when work is spilling into your personal life. It's important to understand that you may not make money on this hire, but your life and practice experience are likely to be significantly better.
Thank you, Reed. That was really helpful. I really appreciate you focusing not only on some of the financial, costs that might come with an APP, but also a lot of the non-financial upsides, which are really important to focus on as well, from a personal standpoint. There's probably a lot of people who are wondering how they can help figure these things out. Do you have any advice for people if they're thinking about this and they want to sort of start crunching the numbers about places they can turn to help figure this out in their own practice?
I think as a rule of thumb, looking at that wait time, is it starting to push out to 3 weeks? I do think looking at the types of patients you're seeing lots of follow-ups. Those are patients that are easy to unload, and you can get numbers on how many of your patients are EMG follow-ups, MRI follow-ups, post-op follow-ups as a percentage of your practice, and then how many new patients you're seeing as a percentage as well. And unloading some of those follow-ups to get new patients really will make room for those new patients in your schedule and bring that wait time down.
Thank you. And just a reminder to any of the attendees, if you'd like to put questions in the chat, we'll be keeping an eye on that too, if anybody has any other questions for Dr. Hoyer as we go along. All right, I'm going to move along to Dr. Hahn, who's going to talk about the process of hiring the right APP.
Thanks, Samir. Thanks for letting me participate here. Are you seeing the full screen version?
I am.
Fantastic. Great. All right. And thanks, Dr. Hoyer. Makes me feel better that I made the right decision here. So I'll talk about how to hire the right APP. Where I'm coming from, I realize people are coming from a lot of different practices. I'm an academic orthopedic hand surgeon in Baltimore at the University of Maryland. My practice mix is 50% elective hand and 50% level 1 upper extremity trauma, including fractures from shoulder to fingertip, microsurgery. And my current team is a shared physician extender and a shared APP, who's an NP. So when I was thinking about how to go about hiring the right APP, I broke it down into three parts. Before the hire, where you're envisioning the role and making sure it's the right decision, then the hiring process itself, and then maintaining the hire once you find the right APP. So when I was going through whether or not I wanted an APP or not, I was reading this book, and it helped kind of uh, provide a good framework for how I was going to make this change for my practice. And some of the three pillars it talks about are engaging the emotions for change. So figuring out why are you hiring an APP? And Dr. Hoyer presented a great um, talk on figuring out how you figure out that why. And then clearly defining the role, so providing a clear direction or rationale for this APP, and then creating conditions to enact change, so shaping the path for their success. So when you're hiring an APP, if you're just trying to find someone to do the stuff you don't want to do, while that might be true, that's not necessarily the best reason nor the most cost-effective reason. I think an opportunity for improved patient care, job satisfaction, sustainability, longevity, and productivity for your practice has a bit more of a pull than just finding someone to do stuff you don't want to do. So for me, a couple of years ago, when I was thinking about wanting to hire an APP, I had a revolving door of physician extenders. All my MAs were location based, so no one was specifically tied to me. And so it led to inconsistent patient care outside of clinic. Patients weren't getting communication in a timely manner. The inbox management and support when I was away on vacations or conferences or on trauma call and couldn't get to the inbox wasn't as consistent as I wanted for my patients. My clinics were inappropriately booked. There were long wait times. So kind of like all those reasons that Dr. Hoyer talked about, I started thinking like maybe an APP is the answer. I wanted a consistent teammate who could see patients, both new and follow-ups independently, prescribe controlled medications if needed, make sound independent clinical judgments, provide higher level coordination across patient touch points, whether they need guidance on how to get to clinic or therapy referrals, ordering tests, getting them scheduled for the OR. Basically, I needed a partner or a teammate who was also a practitioner. So once you have the why you want an APP, then you got to define the vision. It's important to know what role you're really trying to fill. Applicants are going to want to understand what their job's going to be. And the people who manage the business side of your practice will need to understand the vision in order to give you the green light to go ahead with the hire. So that means figuring out like how are you going to run clinic? Are they going to have independent clinics where they're completely on their own, or are they going to be parallel, perhaps in an adjacent pod, but they have you nearby should there be a need? Are they going to be an independent provider or a physician accelerator, someone who makes you more efficient and sees more patients, or maybe gets more ORs done, but isn't generating revenue necessarily on their own? Whether or not they have any OR responsibilities, how much admin, inbox responsibilities they have, if there's other opportunities for them that you could offer, such as research or education, if you're tied to like a PA school or an NP school. And then you do have to figure out how they're going to generate revenue um, if if your practice is going to pay for it rather than you yourself. Um, so I brought my vision to my chair, wanted to hire an APP in order to improve the care of my patients, generate revenue for the department through independent clinics, maintain job longevity, decrease burnout. So I got the green light to talk to the practice business manager and basically was told can't afford it. Undeterred, I thought, well, what if I share an APP with a colleague? So fortunately, my partner Chris Langhammer, I went to him and came up or presented the idea to him, and turns out we shared a mutual why for why we wanted an APP. We had similar practice challenges and some motivations. So over a bunch of brainstorming sessions, we crafted a vision of how a shared APP could work. We talked with other APPs. We talked with our old extenders to see what an ideal practice scenario would be and what would be attractive to an applicant. So then we began to shape the path and make sure that should we get an APP, that we had a plan to ensure success. So we actually shifted our clinic and OR days to avoid overlap so that there wouldn't be competing needs for the APP. It would just be an APP with one of us, and there's no awkward, like, well, who are you with today? We consolidated both our post-op protocols, our intake sheets, et cetera, for uniformity so that it wasn't like she had to work with two different people in two different ways. It was just one way. So we had created this kind of financially feasible, appealing shared hand APP position that would benefit the patients, ourselves, the APP themselves, and the department. So with that, we finally got the green light to hire. So you got to get the word out. So we talked to other APPs in our practice, let them know that, hey, we're going to hire. If you have any referrals or leads, anyone in your network, please let them know. Our practice advertised through their standard job listing sites. And I think it's important to be involved in writing the job description. So there was the generic APP position that they had, and when we looked at it, it looked like nothing that we wanted in our position or in our APP. So we were heavy-handed in writing the job description to make sure it was accurate and matched what our vision was. And so for us, when we were looking to make the right hire, we were looking for someone who was willing to learn about hand and upper extremity trauma. It's kind of a niche subspecialty sometimes. So it does require some learning and lifelong learning, honestly. So we also, because we have level one trauma patients, oftentimes they're polytrauma and they have a lot of complex needs, whether social, medical, or logistical. So someone who was comfortable navigating that with the patients, someone who could work with our physician extenders, our ATCs, work with our OTs, our inpatient orthotrauma NPs, and our schedulers to kind of help take care of our patients. And someone who is motivated for independent practice. We wanted someone who would be able to take the skills that we teach them and be an independent provider, even if we weren't present. And of course, someone we would trust with our patients. And I think it's important to hire the right person. Once you feel like, oh, I can get an APP, you might get really excited, but you don't want to hire the wrong person at the right time. You don't want to try to force the fit. And this goes back to why it's important to have a clear vision of what role you're trying to fill and who you need so that you hire someone that actually fits that vision. They've got to fit in with you, your team, and your patient population. And ideally, it's someone you would work with for a long time. And sometimes it's just luck. For us, as we were putting our job description out, one of our inpatient ortho trauma NPs, Katie, was looking to transition from an inpatient to an outpatient role, something more predictable and scheduled. She wasn't specifically hand trained, but she was familiar with and enjoyed orthopedic trauma, including the upper extremity stuff. So it seemed like a good fit, and she was motivated to learn. And she had done independent clinic experience before, so we felt comfortable that she could work towards that. And her other APP colleagues had all great things to say about her, so we felt that she was a great fit. And so once you find the right APP, you got to keep the right APP. So maintaining a culture that encourages open communication and fosters job satisfaction and longevity, I think it's super important. The hiring process can be long and expensive, and you don't want to do it over and over again. So I think starting off on the right foot helps. Introducing your APP to your whole team, clearly define roles early so there's no confusion. So we introduced Katie to everyone to establish her role as a provider and a partner working with me and Chris, not just the support staff. And so making sure that all the office staff kind of treated her as such, as a provider. We check in regularly, maintain communication. So we schedule regular check-ins monthly for now, make sure we're all on the same page. Any issues coming up that we address early, and feedback goes both ways. Make sure that Chris and I are also holding up our end of the deal with whether it's training or expectations or what have you. We had an onboarding plan that was a gradual progression. We didn't want to overwhelm her, even though she was very experienced. We didn't want to overwhelm her with hand pathology right away. So we started with some easy shadowing, see your clinic flow, how you interact with patients, the face or the persona you give for your practice. Also shadowing with our OTs to understand the role they play in our patients' care. Then we started having her see and present patients just like any trainee would. And she eventually moved on to independent post-op visits, people she had seen before surgery, who recognized her, knew her, and were comfortable seeing her after surgery. And then eventually got her started with independent clinics, seeing new patients. But I think there should be a progression towards independence. People should practice at the top of their license. And while APPs are great for maybe taking some post-ops off your plate so you can see news, I think they should also be able to see new patients too, to practice at the top of their license and generate revenue as well. I think it's important to provide the tools to grow and be a lifelong learner. So we include her in weekly didactics that we have for our fellows and residents. We invite her to the journal clubs. We gave her textbooks, create a curriculum to go over hand topics every week so we can kind of get her up to speed. And we encourage attendance at annual hand meetings, which is always fun. And it's important to remember what was important to the APP when they were joining the job. So we've given her flexibility for passion projects, so quality improvement initiatives to make our practices more efficient, better for the patient. She does have a research interest, so we're going to get her involved into that soon. Katie doesn't have OR interest right now, but certainly if she were, if that was important to her, we would try to see how we could make that work. And of course, respect the hours, expectations, etc. So in summary, I think when you're trying to hire the right APP, there's a few ways to break it down. Before the hire, make sure you find the right reason, define it well, and shape the path so that the APP can succeed once they get there. Don't force the fit. Make sure the hire aligns with the vision you had. And then once you found the right APP, communicate and create a healthy culture so that you can form a work partnership for a long time. Thanks.
Thank you, Dr. Hahn. That was great. Combination of some general guidelines to think about, plus some of the nitty gritty from your own experience with that process. So appreciate that. We're going to move forward to Chrissy McAndrew, who is the director of the ambulatory group of APPs at Penn Medicine, and hopefully can lend some insight from her perspective as well about optimizing clinic and OR workflows.
Hi, everyone. Good evening. Thank you for having me tonight. I'm just going to share my screen here. Okay, can you just confirm you can see that? Looks like it.
I can.
Perfect. Thank you. All right. So as mentioned, my name is Christy McAndrew. I'm the clinical director here in the Department of Orthopedic Surgery at Penn. So essentially, I oversee all of our advanced practice providers as well as our RNs. And I do serve as a clinical physician assistant in our hand and upper extremity division. So I'm going to talk a little bit about like the practical integration of an APP in your practice, whether that's the clinic or the OR. Just see here. There we go. Sorry. Okay. So clinic utilization of an APP, there's many benefits, and I'm going to go into detail of some of these. But many of the benefits that you would see for having an APP in your clinic, they work very collaboratively with the hand surgeon and care teams. As mentioned before, provide a lot of consistency. Some of you work in academic centers and some of you not. And while the residents come through and rotate through fellows every year and things like that, the APP provides a lot of consistency because they're there all the time. Patient education, patient safety, of course, increased volume of patients without overburdening the surgeon. They can provide injections and pull those off of the attending schedule, assist with surgery signups, history and physical for surgical signups, and the ordering of pre-admission testing and clearances for surgery. They provide a lot of continuity of care, especially the APPs that are seeing the patients preoperatively, potentially going to the operating room and actually operating on that patient and then seeing them postoperatively and through their recovery. Many times the APPs are streamlining workflows within the clinics and improving efficiency. And they're there improving overall patient satisfaction. So kind of how do you integrate that APP into your practice? So one of the things as mentioned before would be to run a parallel clinic with your attending when they are in clinic. In addition to that, would be to run independent clinics, which means the APP can run independent clinics on a different day when their attending is not in the clinic. So whether that's, the attending's OR day or the attending's admin day, things like that, they can run an independent clinic where in those clinics, they would be able to see anything from a post-op to a return patient that's managed conservatively or even a new patient for the hand practice. When they're running a parallel clinic, there's many benefits to that as well. Many times the APP in the hand clinics can pull off the non-billable visits, such as those post-op visits or the history and physicals, which are non-billable. And this way, this allows the hand attending to see billable visits and see more new patients in their clinic. In addition to that, they can pull off those return patient visits that are managed conservatively. Many times they're pulling off injections. As you know, you cannot bill all the time for an E&M code in addition to your injection code. So many times the APPs can pull off those injections and see those patients on their clinic as well, especially if it's a planned injection. And overall, improving patient access and getting patients in, quicker. Again, in those independent clinics is where those APPs are able to see new patients, and many times they're working those patients up. They're getting all the diagnostic studies, coming up with a diagnosis and a treatment plan, and then even referring back to the hand surgeon when they need surgery. In addition to that, the APP can assist their surgeon with their clinic and their patient load as well. When they're doing this, they're really helping to, again, move the clinic along and make sure that things are running efficiently. So it can be a new patient workup that they're doing. It can be a surgery sign up where, again, they're going in, they're giving that patient education, they're ordering whatever pre-admission testing and clearances are needed, assisting with documentation, especially for those new patient visits, placing any orders that might need to be placed, or again, doing procedures. So many times the APPs are going in, they're doing wound care, casting and splinting, suture staple removal, injections, etc. So again, many times the APPs can run a parallel clinic to the attending clinic. This way, again, they'll have their own schedule of patients and then can also assist in between those patients with the surgeon to expedite their clinic as well. And then as we look at the OR, there's many benefits to having an APP in the OR. So having an APP in the OR, again, provides that continuity of care. So again, the APP is typically meeting the patient preoperatively. They're then going to the operating room and then operating on that patient and then seeing the patient postoperatively. In addition to that, patient safety, efficiency, and smoother flow in the OR. PAs can provide that local anesthesia for all local cases. Again, they can obtain the consent prior to surgery. They place those preoperative orders and the postoperative discharge orders as well. Many times the APP is beneficial because they actually anticipate the next steps. So they're able to anticipate these steps and the equipment needs because, again, they're there and they're the consistent one who's in the operation with their surgeon. They understand the way they operate. They understand, their protocols and the way they do things. They have a background of sterilization, so it's not something that needs to be taught, when they're coming in, because they have that background and understand the sterilization process. And again, then the post-op visit is typically improved since they know the specifics of the surgery because they were in there. So it benefits the APP rather than having to go back and, read the operative report and may not see minor details in there. As mentioned before, there's only certain CPT codes that are actually billable for first assist for a physician assistant. And so you can see there's a list here of CPT codes that are billable for the hand, the forearm, and the wrist, and there's many that are missing here. So your standard, bread and butter cases, your carpal tunnel, your trigger fingers, certain debridements, amputations, things like that, none of those you're able to bill for first assist through many of the carriers. And so again, As mentioned before, this is carrier specific, but some of the CPT codes are non-billable for a first assist. And that's when you have to think about potentially utilizing the APP in the outpatient setting to actually generate revenue and see new patients rather than being in the R. And then, of course, there's wide awake local anesthesia cases. And many of these are done in the office in a procedure room. And there's many benefits to having an APP actually assist with these procedures. One, they can act as both the scrub tech and the first assist. The PA can do the consent, they can do the pre-op orders and provide the local anesthetic. They, again, a consistency, having that same provider in those procedures with you week after week. They anticipate the next step. They know the equipment needs. They're there to help turn the room over. And overall, I think all of this with improving the efficiency helps to increase the volume of cases per day. Sometimes some of our surgeons are even doing about 16 local cases a day. Because again, they have efficiency with having their APP with them in these procedures. And then again, that continuity of care. So kind of why does it make sense and why do we talk about this continuity of care? Again, the APP really streamlines workflows and helps to improve efficiency. They're managing many of the postoperative follow-ups for our hand patients. In addition, they're providing most of the patient education and a lot of the rehabilitation guidance. They're monitoring the recovery and many times adjusting care plans as needed. And they build very strong patient-provider relationships. So in conclusion, APPs are integral to modern hand practices. They're providing both clinical and financial value. They're improving access, efficiency, and patient outcomes, and they're improving clinical productivity. Many times they're acting as a bridge between the surgeon and the other members of the care team. So whether this is our hand therapist, it's our surgery schedulers, it's, the perioperative team, they're acting as that bridge to improve communication between the care teams. They're also improving communications to our patients. Many times, as mentioned before, the APPs are the ones who are doing a lot of the patient calls, a lot of times giving, results of diagnostic studies that were completed and answering the patient questions that come through phone calls or through email to our system. They're contributing many times just to the positive culture in general of the practice. And at the end of the day, they're providing high quality care delivery to our patients. So overall, I think that, again, as mentioned before, it can be a very personal decision, especially if you're in a private practice, but there are many, many benefits to having an APP in your hand practice. Thank you.
Thank you, Chrissy, for sharing some of these ideas about optimizing the role in all of our practices to make it as efficient and positive as possible. I do want to save some time for questions and answers at the end, so we're going to go right ahead to Dr. Busbekian, who's going to talk about balancing efficiency with education.
All right. All right. Can everybody see my slides?
Yes.
Excellent. All right. So, Samir, thanks for the invite, and everybody who tuned in, thank you for tuning in. My name is Mike Bospicki. I'm the residency program director and hand surgeon at Rutgers, New Jersey Medical School in Newark, New Jersey. So, no relevant disclosures to this talk, but these are actually the relevant disclosures. Now, the first thing I want to start off by saying is that, as far as this goes, everybody seems to have different models, different practice patterns, and a different situation with their involvement with academia, private world, ownership, things like that. So this isn't necessarily the goal of this talk is not necessarily to be like, this is what you should do, because it's not, because in all reality, you all have different practices than I do. And what I really want you to take away from this is kind of the steps and the reflection that it takes to figure out how it makes sense to be able to educate while being efficient at the same time, because it's very easy to fall into the trap of becoming increasingly busy clinically and losing out on your teaching responsibilities, or vice versa, spending all day teaching and doing like 3 carpal tunnels every 6 days, right? So that's not ideal. So I joined Rutgers, New Jersey Medical School faculty in 2016. And because of a good case of Stockholm syndrome, I'm still there. We're a level 1 and micro center. In 2017, I became the associate program director and have been the program director since 2021. And another disclosure is our PA, who's been there since 2003 in the hand division, is I would argue the GOAT. One of the other reasons that I was glad Samir asked me to talk about this is that I sit in 3 different realms at our institution. I sit on the GME, so I have the educational hat. I am one of the 2 people on our practice finance committee, so that's our business hat. And then I'm the president-elect of the medical staff, so I have that hat on for, basically what works for the hospital. So I was really glad Samir asked me to talk about this because this is kind of the world I live in every day. Now, the realm of academia, if you kind of look at it, you can break it down into 3 categories: patient care, efficiency, and education, right? And, I intentionally made this graphic look this way because it makes them look like they're all competing with one another. But in actuality, they don't have to compete with one another. They do not have to be mutually exclusive things, and you do not have to kind of sacrifice one to find the other. So, as a native Philadelphia area guy, I figured I would start with a little Thomas Jefferson here with "We hold these truths to be self-evident." And I put truths with a question mark for a reason. Because there are certain things that are true and certain things that are not true. And a lot of these depend on kind of how you're looking at it and from what, side of the coin you're looking at. So common thing is people will say, I'm faster on my own, faster without a resident, I'm faster on my own. Okay, maybe, maybe not. Some people look at academia and say sacrifice is a necessary part of academics. I would argue that that's also not true because there are many benefits as well. So, the person with the martyr complex who wants to make it seem like they're the hero of the day, it's not necessarily always true. Volume equals fulfillment. Maybe it does, maybe it doesn't. And all hope is lost if you go into academics. I would argue that I'm on the hard side of that's not actually true. So we're going to get into some of these and kind of how we've addressed these, in our own practice and in our own model. And in the interest of time, I'll try to be efficient. So I decided to try to find some literature about this, right? Because I could get up here on my soapbox of why I love being an academic surgeon all day long, but quite honestly, it's irrelevant if I can't back it up with some sort of, actual data. So most of these studies are actually born out of general surgery for a lot of reasons, mostly because there are way more general surgery programs and because they probably have spent more time studying this. But in this one study that they published last year in the Journal of Surgical Education, they looked at residents increasing the value of surgical care, right? But again, this comes down to why value. Well, how do you define value? Which is why I have it in quotes there, right? So when they looked at the outcomes that they measured, they improved. Their return to OR at 30 days was decreased by about 24%, readmissions down 17, length of stay down about a half a day, and emergency availability of a provider in-house 14.5%. Okay. And the costs are not increased. Now, the question becomes, and this is why, I have this caveat about different people's, model is, does it impact the hospital's reimbursement or your reimbursement or your practice's reimbursement? So as I said before, there's a bunch of things you need to reflect on and think about from a practice standpoint. And one of them is the hospital's versus your own practice or your own personal reimbursement when you're looking at that value. What are the metrics that matter? What do you care about? Operative time is increased with a resident. Okay. I'm not going to deny that. But you have to look at, is that increase in operative time worth the decrease in your 30-day admissions or 30-day return to the OR, your readmissions, your length of stay, things like that. So again, depending on what value is defined, what is, the value defined and what are the metrics on which you're measured, that actually could be a great return on investment. Others have studies have shown the same thing, not to beat a dead horse, but this one showed hospital stay was unchanged, but mortality was down 42%, and the educational profile of the hospital increased, right? How does a new program impact efficiency? No significant time in OR change, length of stay, 30-day readmissions, everything was about the same. The reason I put all these studies in here is because you can basically find any study to support it. But I would argue that the most critical thing is how does your institution define value and how does your institution define efficiency and by what metrics are valued at your institution? So, as a side note, again, I'm not saying academics is better. It has its upsides and its downsides, similar to private practice, similar to private academic, similar to employed, whatever model you're in. But, it's not better. It's just different. Okay. But the reason that I point all these things out is that it means you can make it work. And I would argue that the vast majority of people who have not been able to make it work haven't really stepped back and kind of looked at, again, what those metrics are and how value is defined at your institution and within your practice. And I think if you don't know that and kind of know your own world, there's no way you can make it better, make it efficient, nor can you balance anything because you don't really know where you are. You can find evidence that can show any model will work. You can find papers that say residents are the greatest things in the world or the worst things that ever crossed your path. And quite honestly, that just shows that you have to know how to utilize, your resources and balance what you can. And, again, this is not a rocket science thing. It's just to sit down and spend the time thinking about it. You just got to figure out how to make it work. So when you define efficiency, right, measurable things, and these are things that our institution really looks at, is how many patients are you seeing per day or per hour of clinic sessions? Okay, fair. Your operative time, which is something they've been cracking down a lot more on lately, particularly at our institution. How many consults are seen by your service as well as by you as an individual, right? Which at a level one trauma center is very based on call and seasonality in the Northeast. What are lengths of stay? In an urban center is often much higher than you'd like it to be. So anything that you can do to decrease your length of stay is helpful. And what is your readmission rate? Again, in a urban center, that's a very high thing because of lack of resources. There's also, as Reed said earlier, immeasurable things like peace of mind, right? Your ability to go home and decompress, your ability to be with your family, your ability to read to your kids at night are all very, very important things. And these things do not, again, all have to be adversarial to one another, and you got to figure out how to make that balance work. But I would argue that peace of mind is definitely an important thing. And again, one of the other things you got to sit back and think about, along with your measurable and your immeasurable things, are your institution's model, right? Who's hiring the APP and who can bill? In our particular model, the hospital actually hires the APP for us, okay? Which means that their services cannot be billed for at all. So since I can't bill for RPA, how I utilize RPA's services and how we have him seeing patients and what we have him doing is a lot predicated on that because we can't use that as a revenue generator. So also important thing to think about. So, the bottom line of this is that everything is a tool. Teaching is a tool, right? Your APP is a tool. Your resident is a tool. Your own service is a tool. Your office is a tool. Everything is a tool. And really knowing how to use the tools in your toolbox is the key to success. Okay. So residents, the balance there is you have a duty to educate the residents, right? If we're going to continue the whole medical system the way we have it built, we have a duty to teach those just like those above us taught us. But important thing is you have to know the GME rules. And one of the most common citations that residencies receive is a service to education imbalance. If the residents or the GME feel that the service to education balance is in favor of service over education, that's a good way to get your program in trouble, citations, probation, things like that. So, the important thing is you have to make sure that the education is the priority over the service, right? APPs, whether you have an MP or a PA, depending on your practice in your state, they do not rotate off the service, right? And, that was one of the points earlier with continuity is that they do not rotate out of the service. They know how the service runs, they know how the patients are, they know the protocols. It is a very, very invaluable resource to have, an APP that is really, in tune with how things are. They are a critical asset. I joke around all the time. I could not run my practice without RPA. It's 100% statement of fact. I mean, there'll be times when you have a full stacked office day, you still have 20, 30 patients to see, and somebody gets shot or falls off a roof or flies off a motorcycle, and I got to leave, and he can run my entire office hours by himself, and he's awesome. And APPs and PAs have, APPs, PAs, MPs, they all have very different skill sets. I mean, they're extremely qualified. The care that they provide in the office, I would argue in certain ways is better than what we do. So, you really have to think about this. from a standpoint of optimizing your resources, optimizing your tools. And regardless of what practice model you have the opportunity to optimize. And I would argue that's one of the most important things. So the slide that I will close with is, I know this is an extremely busy slide, but it is a little bit on purpose. So this is my partner and I's weekly schedule, right? And the trainees are in black font and the PA is in red font, right? The reason we did this is that we did this originally with index cards, but I was too embarrassed to take a picture of a bunch of index cards with different color Sharpie on them. So I made it look nice. So, this is the balance of the hand service at our institution. And, what we did was when I started, my partner and I sat down and we made the schedule, both of our schedules, and went over it and started moving the index cards around to what makes sense. And the interesting thing is that that changes periodically as one of us gets busier at an offsite office or, a hospital-based clinic gets busier. These are things that you need to keep fluid over time. So one of the other keys is not to fall into a rut and keep everything the same the entire time. That balance is going to change. And this is the balance that we've made here is to maximize the educational benefit of the resident while keeping things efficient, while having our APP, who, is an absolute machine, right? So we've figured out a way to optimize education, optimize efficiency, and in our model, this works. And again, this is subject to change by trends in our practice, which sites we're busier at, or by GME or resident, changes. So I think, the point of this was not necessarily to, sell everybody on being an academic hand surgeon and certainly not a program director, but, the whole thing was that these are all the things that you need to take into account when you're considering what to do and kind of how to optimize, all of the different hats you have to wear. So hopefully these were some helpful tools for everybody. This is a picture of our hospital, which I've never seen it that clean or green, but there you have it.
Mike, thank you for sharing that. I would echo what Dr. Hoyer said in the chat box that one of the real themes of a lot of these talks has been how different all of our practices are. I think it's really interesting to ask you, since you wear so many different hats at your institution, that if they were worn by different people, they might oppose each other a little bit. Sometimes, whether it's from the finance side and the education side and things like that. For people like Reed and myself, when we're in private practice, an APP may cost us something, but I can say I'm okay with that, right? I want the non-revenue pieces of the benefit that it brings to my practice, my patients, and my life. Whereas there are times where I think as an institution has to approve a hire. We heard Dr. Hahn talk about how as an individual wanting to get an APP, they said basically that's probably not going to work. So figuring out a different sort of model. So do you have anything you could share with some of our attendees about ways to kind of get a institution to buy in on spending money on you, especially if it's not fully reimbursable? And also as like an individual doctor, if you have an APP but you're not getting the benefits of their reimbursement, how do you strategize around that from a financial side of things?
Yeah, I mean, us not getting the benefit from the reimbursement, since we don't pay the salary, is not as big a deal because it's not a system that has to sustain itself. But, the hard thing is, and, as kind of the guy who's in the middle of a lot of these discussions with the hospital, is you have to figure out who is the person who has to authorize it and what do they care about? What do they value, right? So, one of the things is that our hospital, for a while there, was trying to make a big push with the integration of different academic systems in New Jersey to make itself kind of a bigger GME kind of elephant, right? So what we did was we then went back and found every citation of service to education imbalance, different things where an APP could be helpful with, either helping out with the clinic or scheduling or seeing patients or giving the injections, things like that. And then we attacked that. The thing is, it's one of those things where you just have to know what the person who holds the reins actually values. And if you can figure that out, it's actually not as hard to get something approved, right? So, if it's access to care, that's another great one. Especially if you work in an urban environment, you say, access to care, patients don't have resources. It's hard for them to get in. The wait times are forever. If we have a, PA run clinic on Thursdays, that would decrease the burden significantly. So it's just a matter of figuring out what they value within their mission statement, and oftentimes you can get a lot further than you think.
Thanks. There's a question in the chat box here that I think would be great to ask the panelists. Maybe Chrissy, especially, you could weigh in on this about balancing, what the PA's personal experience might want to be with what is most useful from a revenue standpoint, things like that. Where there's overlapping um, resources. Maybe you could kind of lend us some insight as to, Dr. Hahn talked about hiring a PA. Maybe you could talk about, how is it that PAs are looking at jobs, and what can we do to make sure that it's a two-way street with fulfillment?
Yeah, I think that's a great question. And retention is something that I value. And I'm proud to say that many of my APPs have been with our team for a very long time. So I think there's a lot of things that go into this. One, work-life balance is huge, especially at this day and age. And so I think making sure that we are not burning out our EPPs, making sure that they are working very reasonable hours, making sure that there's reasonable expectations and that they have kind of layers of support to also assist them through their practice. So for example, we have surgery schedulers who help with the administrative side. We have RNs who help with the triaging of the phone calls since our APPs are in the OR, they're in clinic all day. So I think just the work-life balance is very important. In addition to that, we talked a little bit about kind of the balance between the OR and the clinic and kind of like how do you manage what they might want versus what is reasonable and what's going to generate revenue. We've done a lot of work on this over the years at Penn. And we have realized that we are not getting a lot of reimbursement for first assist in the OR for our APPs. And so I think some of it is certainly, just having that discussion with the APPs that, where is the benefit and what's going to help us with our mission. Again, that might be patient access, getting patients in the door. And then in addition to that, we very much do value if an APP really wants to be in the OR. And so we try to work around that. And many times those that are, it has many benefits and provides that consistency to have them in the operating room, especially if a surgeon is, running many cases a day or running 2 rooms and things like that. So I think it's definitely a balance between the two and just supporting the mission of your division, your department, or your institution.
Thanks, Chrissy. Other thing I was going to add is for those of us that work in institutions where the APP is compensated by the institution and not by the surgeon directly, we have had more of a push towards the APPs generating a certain number of RVUs in order to justify their worth, right? And so I think many of us physicians who value having an APP, I think it's in our best interest to make sure that we are feeding our APPs those RVUs as appropriate, whether it be helping in the OR, letting them do the injections or nail bed repairs, as Dr. Nord has pointed out in the chat, that our APPs find that that is also fulfilling in some way, that you don't have to necessarily be in the OR, but you're like caring for patients, you're doing injections, you're doing procedures in a way that maybe the bottom line for us physicians is not the same. But I think, as Dr. Puri pointed out, like I'm okay if my productivity is a little bit lower if I have an APP who offloads the majority of my headaches, but also like makes my life better and also loves their job, right? And I think that's a fine balance, but that's a great question from Dr. Jabor, sort of figuring that out. And I think it's worth having that discussion up front. And even if it means that your productivity takes a hit a little bit, I think in the long run, it makes your life a little bit more valuable and happy as a result.
That's
I don't
actually a
know.
really good point. And I was just going to add, autonomy is very important to allow the APP to work at the top of their license. And so I think you made a really good point there in saying that, like, yeah, they might want to be in the OR, but the hospital, the institution wants us to have them generate revenue and RVUs in the clinic and things like that. But I think there's also so many positives on that side, as you mentioned, with giving them that autonomy to do those procedures, see those new patients.
I think it's, I don't know if people are looking at the chat, but just want to echo what Mike wrote. And I think that it really is understanding what your practice setting is, what you need to have help you, and be setting clear expectations when you hire someone. If you tell someone, you might work in the OR, figure it out, but you have no intention of letting them work in the operating room, and they want to work in the operating room, they're going to leave, right? If you say, hey, this is not an operating room job, I need help in the clinic, you're going to see new patients, you're going to see follow-ups, you're going to take care of post-operative patients, that's what the job is. You're going to find someone who is less interested or does not care about working in the operating room. That's going to be very important to set up front. If those expectations are sort of wishy-washy, or you're like, well, I think you're a great PA because you have all this experience, but I'm not going to give you the job that you're looking for, they're going to end up leaving, and you're going to have to do, what Alex mentioned earlier, and hire somebody else. So I think it's very important to know, like, the practice you're in, what you're looking for, and find someone who's also looking for that job, so that everybody can be happy. You don't have to make the job meet someone's expectations. You need to find someone who's looking for the job you're offering.
Well, thanks everybody. That was a great discussion at the end there after a great session. Really appreciate all the talks that we got. I think we're hitting our time limit here, but as mentioned in the chat box, this will be available later for review if anybody wants to come back to some of these discussion points and pick up some of these tips and tricks that Dr. Bosbekin is dropping here in the chat about how you get yourself a PA approved. These are very helpful tips overall. But thanks again to Sahi for his role in organizing these things, and Dr. Hammond. And all right, anything else to add, Sahi?
Yeah, just go to handsurgery.org within the next week if you want to watch a video of this. If you have any questions, put them in the chat. We can always respond later as well. And then our next practice series talk will be in August. It'll be about negotiating, renegotiating contracts, figuring out your worth in the market. And we look forward to a great webinar. And thank you all for joining us. And thanks to our panelists and Dr. Puri for being an awesome moderator. All take care. Have a great evening.